So we see we're going through the interval between the two extensor tendons. We do use a careful mammary elevator. I initially was opposed to this, but we release it proximally to give us a little more excursion of the capsule. That probably gives us another couple of millimeters. I initially was very much opposed to this, but I was talked into this by Lobau Jr., and that's what I do routinely at this point. You see the wild osteotomy done fairly parallel to the plantar aspect of the foot. And then we push this as far proximal as we can, about 10 millimeters, and fix this with a dorsal plantar K-wire. Now, you're going to cut away some of your landmarks, so I use a little measuring device and I mark how long that piece of bone is, because I'm going to take a rongeur and clip a little of that away. So then when I put it back together again, I know how long it should be. These are what I call pigtails. They're hollow, and there's a suture that goes inside of it called a suture lasso. One's left-handed and one's right-handed, and you can actually get into this small joint. Dr. Neri will show how he did using a small needle and a needle holder, and that's very courageous of him, but it's very hard to do. Now, I'm doing this just in a piece of tape, and you can see how I've used this little, what I call a pigtail, and I'm pushing that suture lasso through. And now I'm putting the suture, this is an old fiber wire, and I'm going to pull it through what I would call the plantar plate. And you can see that you just don't have much room there. And now I'm going to pull it again, and I'm going to punch that little lasso through, and now I'm going to put the suture in again, and pull it up. Now I've got a U-shaped suture that engages the distal aspect of the plantar plate. I feel very fortunate. Many of these tears are longitudinal, they are transverse and distal, so they're actually, you can get to them. Now you see you have a left turn and a right turn. Now in this particular patient, she has a grade 3 tear, so she has a longitudinal tear laterally. So I'm using my little pigtail, and I've gone ahead and passed the suture through this, and I'm placing a side-to-side horizontal suture to repair that longitudinal tear. She has a transverse tear as well, so we call that a grade 3. We're going to clip that suture, but now I've addressed the longitudinal tear. Now this is another very quick way to do it, and it's called a microscorpion. It has a little trap door that catches that suture as you come through, and if you have enough room for this, this is very speedy and nice, but there's not always enough room. But you can see it delivers the suture right through, and that's how quickly you can do it. The shoulder surgeons are very, very fast now with this because they've seen this and used this. And there, I've just punched the suture through. It takes a little comfort, and usually using a cadaver will make you more comfortable with this. I would doubt that it would be smart to just try this on your own without trying the cadaver first. And now I'm putting a second set of sutures in. I like to put 2 sutures in so that I have 2 different sets of fixation. They're usually colored because you can really get confused with what ties to what. So I use like a blue one and a white one because I'm going to pull them up through separate holes in the proximal phalanx. Now you can see here's my second suture that I'm delivering at this point. And I'm actually just using hand distraction. We do sometimes put a K-wire on the base of the proximal phalanx and we distract it. But in this patient, I'm actually just using longitudinal traction. Now you can see I pulled on those sutures, and I've captured the plantar plate very nicely. Now you really have to turn this toe downwards, and this is a drill that we drill 2 drill holes through the proximal phalanx in a like fashion, exiting on the plantar aspect of the proximal phalanx. Some like to do a crisscross. I still do sort of a vertical like suture. And then we have a suture passer that we pass through to grab 2 sets of those sutures, and here you see in the model going through with the suture passer. There's a little trocar that goes through. It has a nitinol loop, and again, this is so small. There's only a few millimeters in here, so you really need tiny instruments to get in here. Now I'm pulling those 2, the blue and white sutures, through that drill hole and pulling them up to the top. This sometimes is one of the more difficult maneuvers to do. You can see here's passing it. It has a little sheath, and then it has the nitinol loop that now I put my clamp through the nitinol loop, pull the sutures through it, pull them out, and then pull them dorsally as well. And I want to give my appreciation to T.J. Kim, my associate, who helped me with this video, who did a masterful job in cutting this down, because it took a little more than sutures. Again, there's a white one and a blue one, and passing those up. Now we've got them in place, and we've delivered both to the dorsal aspect of the proximal phalanx. Some ask, how far up do you go? You're sort of limited by the metatarsal head. You want those sutures placed at least far enough so they won't cut out of the friable end of the plantar plate. And you obviously are pulling it up to the bottom of the proximal phalanx. Now, how much lengthening do you do to the while osteotomy? Usually 2 or 3 millimeters, and that gives you, you're going to make up the defect or deficit in the plantar plate. So we've got that now. I fix it usually with a couple of spin screws. And now I'm ready to tie my sutures. And so we usually put the toe in about 20 degrees of plantar flexion, and then we tie blue to blue, white to white to complete the capsule repair. Once we've held that toe in 20 degrees of plantar flexion, and then we make this tie, we find that we can bring the toe really into almost a neutral position. It's rare that we actually overcorrect it in an excessive plantar direction. Here we are doing our ties on this lady. And what you'll see when I'm done, it's not quite perfect. There's still a little medial inclination of you see on this toe. You can see it there from our dorsal view, and you'll see it once I clip this last suture. There's still just a little bit of medial deviation that I don't like. And so now what I'm going to do is I'm just going to do a reefing suture, which I've done in the past for years, in the collateral ligament and in the distal aspect by the proximal phalanx. And I'm going to reef that and tie that and bring the toe into better position. When we have a grade 1 or a partial grade 2, we will usually complete the tear so that we have completely taken down the distal aspect of the, there you see it's nicely aligned at this point, and the drawer is gone. That's one of the things that Andy had asked me yesterday. How about the stability? And that is a very, very stable toe at this point that completes our repair. There you see the radiographs at the conclusion of the procedure. Now there's so many little tricks that go along with this that time does not prevent us to talk about, and that will conclude my presentation. It is my pleasure now to introduce to you Coughlin from Sao Paulo, Brazil, our friend and colleague who has been very much of a thought leader in this topic as well, who has certainly some excellent experience in treating this and some results.